Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Listeners, welcome back today. We're starting a new panel discussion with Chuck Dowell and myself, but we're discussing non-orthopedic causes of pain that present in orthopedic clinics. Chuck had this idea, so Chuck, I know you had an example, I think, that you wanted to talk about, so please go right ahead.
Thanks, Sam. I appreciate that. I had a patient present to clinic. He was a 68-year-old gentleman who came in complaining of chronic low back pain. His symptoms had been going on more acutely for about a week, but consistently for about 3 months. He had no inciting incident, no fall, no trauma, no injury, just said he had what he described as a dull aching pain diffusely throughout the lower thoracic and mid-lumbar area. He was a bit of a poor historian. He looked older than his, kind of stated age. He didn't really know his comorbidities. He hadn't seen yet or doesn't go to the doctor regularly. His examination was rather benign. He had some diffuse tenderness throughout his lumbar spine. Motor sensory exam distally was normal. I got x-rays, and on the x-rays, he had diffuse arthritic changes throughout his lumbar spine, but more significantly, he had what appeared to be a calcified abdominal aortic aneurysm. When I measured it, it was approximately 9.6 centimeters in diameter. I thought and/or was concerned that this was the source of his low back pain. Luckily enough, I have a radiologist that reads a lot of our MRIs. I called him and asked him if he would take a look at it. He looked at it and immediately had the same reaction I did. Happened to have his vascular radiologist right next to him, also had the same reaction. And we all kind of concluded that likely this is the cause of his low back pain. And we sent him to the emergency room. The vascular surgeon agreed. He ended up doing a surgery on him the next morning, and he was discharged from the hospital 3 days later with complete resolution of his low back pain. So I thought this was a good case about patients that often present with musculoskeletal complaints, but it may not be necessarily a musculoskeletal concern that's causing their symptoms. And I thought it'd be good to have a discussion regarding these similar complaints.
Yeah, it's a great case. So he had a 9.6 centimeter, is that right? 9.6 centimeter AAA. I mean, that's a great catch, by the way.
Yeah, I mean,
9.6. What is the cutoff for surgery? I forget.
5 and above is watch. 6 and above is typically surgery. I had to, think through my database of if I can remember that or not, for my urgent care days. But when I talked to the radiologist, that was, 5 and above, they monitor every 6 months, get new imaging. 6 and above, they typically consider surgery. And luckily enough, this was calcified. And, a lot of the times on these lumbar spine films, we can see calcification of the great vessels. And so for him, it just happened to be a significant dilation.
Wasn't there something too about you could feel the pulsation through it in the abdomen? And I don't know. I think I've tried that, and I'm like, I don't know if I really can appreciate that or not. But what are your thoughts on that?
Yeah, so it was interesting that you say that. Again, he was a poor historian and kind of talking to him about, hey, I don't think your back pain is coming from your lower back. I think it's coming from, this abdominal aortic aneurysm. He said, can you go get my wife in the waiting room? And I brought his wife back, and she was a much better historian. And she, of course, then says, oh, yeah, don't you remember how you were rubbing your stomach earlier today and saying that your stomach was bothering you? And you kept putting your hand on your stomach and rubbing it, saying, this is where the pain is at. And so then that clued me in that definitely, I think, as you said, the, aortic aneurysm was likely causing his symptoms. And he's definitely get not just low back pain, but also this mid-stomach pain as well.
Yeah, that's a great catch. For those of you listening that know anything about AAAs, if they rupture, it's game over. You're done. And I'm glad you picked that up. I'm glad you were able to find it, because you probably saved his life by finding that. So kudos to you.
Yeah, I appreciate that. Yeah, I can only think if, I just sent him home on some meloxicam and normal low back regime. He was a bit of I don't like to use the phrase, but a ticking time bomb. As you said, I have friends who have had ruptured abdominal aortic aneurysms in the ER, and the patient unfortunately still doesn't survive because it's such an acute thing. It's seconds before they completely lose all their blood supplies. So yeah, I think it was a good catch. And I've had some of these throughout the years where people come in with orthopedic complaints and they're not necessarily always orthopedic complaints. And I think it's important sometimes as a practitioner to sit back when the symptoms don't match and or the patient's complaints don't match, sit back, take a minute, think through it and say, hey, what else could this possibly be? And I thought it'd be fun if we could, discuss other things that we've seen that potentially are not orthopedic complaints that have gone on to have resolution of their symptoms.
I think that's a great segue into the discussion for today's panel. And I also think that that is a fantastic example of don't get tunnel vision when you're looking at your x-rays. You obviously saw this calcified abdominal aorta. You have to think about things like peripheral vascular disease. And I thought a good way to set this up was to go through different things, like back pain, neck pain, and talk about different conditions that might set that up. But don't get tunnel vision looking at x-rays. There are a lot of things that can cause orthopedic complaints, and it's not always orthopedic conditions that are causing it. So for our new colleagues, please make sure you pay attention to that and trust your instincts, trust your gut, but don't look just at one thing. Look at the whole picture that you got in front of you. You get a lot of information from an x-ray, and it's not always orthopedic. So great pickup there, Chuck. That patient owes his life to you, it sounds like. Now, if we are going through this as like different orthopedic systems, I just kind of came up with something. I thought it would be great to start with a case study, but maybe just in general back pain. So, okay, so a AAA caused this patient's back pain. What are some other things, Chuck, that you could come up with that might cause back pains? I found a couple of things. Referred pain. What about referred pain from the kidneys or pancreas or other internal organs? Have you ever had anything like that, Chuck? I think I've had some. Kidney stones is the first thing that comes to mind. A lot of times with orthopedic clinics, somebody with pancreatitis, they're going to have other systemic symptoms, so they're not going to show up in an orthopedic clinic with back pain, but there are a lot of things that can cause it. So just curious what your experience is and what your thoughts are on that.
Yeah, I think I agree. Throughout the years, I've had similar scenarios of low back pain. I'm lucky enough, I do orthopedic urgent care, but I also do regular urgent care on the side. So I can't kind of keep that medicine brain turned on. And so if I have like an elderly female that comes in complaining of a dull lower back pain, I oftentimes ask them questions about urinary complaints to see if this is potentially a UTI, or as you said, potentially a nephritis, pyelonephritis, kidney complaint that's causing their symptoms. Are they having blood in the urine that's consistent with a stone? And then similarly, I've had some gallbladders that have had mid-thoracic lower back pain as well, kind of upper scapular pain. So again, it's one of those things where, as you said, and we've talked about this on a previous episode, don't get tunnel vision into somebody comes in complaining of low back pain. You were taught to do these 6 examinations and only do these examinations on them. If I go in and I examine somebody and they have no palpable tenderness or very mild palpable tenderness throughout their lower back or paraspinal area, fairly well maintained range of motion, and their x-rays show some mild degenerative disc disease, I start thinking outside the box. Okay, what else could be causing their symptoms? Because it doesn't seem like it's a musculoskeletal complaint. And I've had a couple colleagues come back after listening to one of our episodes and say they never thought about it. But I think it's important to go back and look at the x-rays, whether it's later on or when you're dictating. Prior to this episode we started today, I was dictating yesterday's charts. And I think now in this calm environment where I don't have 15 patients in the waiting room, I can take a better look at some x-rays and see some subtle findings where I'm like, I wonder if that's a cause of their symptoms. And so I think it's really good to go back and look at these x-rays a lot of the times to see if you can see something subtle on there that potentially could be causing the symptoms as well. But that's my experience. What's yours?
I've seen kidney stones. I've seen UTIs causing back pain. I can't recall seeing somebody that had an infection, although I have some experience with people that have things like epidural abscesses. And those are oddball, weird, and they're usually have a lot of morbidities because they're not found fairly quickly. So if you get somebody with this vague pain and you can't put your finger on it, keep infection on your differential. There's always something that could be causing pain. But yeah, I haven't had, I don't have the medical experience like you do with the urgent cares, but I have had a few things that come through. I think back pain certainly can be caused by something else. So one of the things I want to talk about later is systemic disease. What other kinds of problems can cause this, and certainly things like rheumatoid arthritis could cause back pain. So there are a lot of different things that could show up. Listeners, please follow up next week. I hope you can join us at one of our upcoming CME meetings. We have our musculoskeletal ultrasound workshop from February the 28th through March the 2nd in Charlotte this year. We also have our Ortho in the West annual conference, March 28th through March 30th. Look on paos.org for details.